Hello, everybody. My name is Dr. Jessica Bender, and I am happy to be here today. I'm a full-time faculty member with the Hybrid DPT program at NAU. Today's lecture, we will focus on an important topic in the field of physical therapy, developmental coordination disorder, also commonly known as DCD. We'll explore the challenges faced by individuals with DCD in motor coordination and discuss strategies to help them overcome these difficulties. Throughout the lecture, we'll explore various aspects of DCD, including its definition, prevalence, diagnostic criteria, and contributing factors. We'll also explore assessment and evaluation methods used to diagnose DCD accurately. Hopefully, by the end of the lecture, you'll have a solid foundation in the understanding of developmental coordination disorder and the tools necessary to provide effective interventions for individuals with this condition. So what is DCD? First, it's important to understand motor coordination. Motor coordination plays a crucial role in our everyday lives. From tying our shoelaces to playing sports, our ability to coordinate movements is essential for functional independence and participation. For individuals with DCD, however, these seemingly simple tasks can present significant challenges. Kids with DCD may struggle with performing tasks that require fine motor skills, gross motor skills, or both. The motor challenges experienced by these children with DCD can have significant impact on various aspects of their lives. So the definition of DCD is it's a neurodevelopmental disorder characterized by significant difficulties in motor coordination and skill acquisition. It is a lifelong condition that affects children and can persist into adulthood if it is not addressed. It's a chronic and usually permanent condition. And performance in daily activities that require motor coordination is usually substantially below what is expected of the person's chronological age. Prevalence. Understanding the definition and prevalence of DCD helps to lay the foundation for comprehending the significance of this condition and the need for effective intervention. It is estimated to affect 5 to 6% of school-age children, 1.7 to 2.8 times more likely in boys than in girls. It becomes evident during early childhood when the motor milestones are expected to be achieved, and it does persist into adulthood. DCD is not simply being uncoordinated, and it does impact the ability to perform everyday tasks such as ADLs, work, and school. This is important to understand. A developmental coordination disorder diagnosis cannot be made by a physical therapist. Diagnosis is typically made when the child is around 5 years old or older. So there are specific DCD diagnostic criteria that the patient needs to meet all 4 of these in order to get a diagnosis of developmental coordination disorder. And they are motor performance deficits, participation in ADL deficits, early onset, and no exclusionary conditions. So for motor performance deficits, it's the acquisition of motor skills is significantly below age-expected norms. It may appear as being clumsy, dropping objects or bumping into things, or slowness or inaccuracy of motor skills, having difficulty catching or throwing, difficulty using scissors, and participation in ADL deficits. The motor skill deficit will significantly and persistently interfere with activities of daily living appropriate to the patient's age. For example, self-care and self-maintenance, and it affects academic and school productivity. And then early onset. The onset of the symptoms is in the early developmental period. Motor coordination difficulties are present since early childhood and typically become noticeable during the preschool years when motor milestones are expected to be met. And then finally, no exclusionary conditions. The motor skill deficits are not better explained by an intellectual or visual impairment and are not attributed to a neurological condition affecting movement, such as cerebral palsy or muscular dystrophy. It's really crucial to note that the diagnosis of DCD should be made by a qualified healthcare professional using standardized assessment tools and observations. The diagnostic process involves gathering information from parents, teachers, and the individual themselves, as well as conducting physical assessments and standard tests to assess motor skills, coordination, and functional abilities. Accurate diagnosis is really vital for identifying individuals who would benefit from intervention and support tailored to their specific needs. Etiology. So DCD is really a complex condition that can arise due to various contributing factors. It's important to consider the interplay between genetics, environmental, and neurological factors when understanding the development of DCD. While the exact cause of DCD is not fully understood, the following factors have been identified as potential contributors. Genetic factors. A family history of DCD or other motor coordination difficulties may give the individual an increased risk of developing DCD. Environmental factors. Prenatal factors such as maternal smoking or alcohol consumption. Also, babies born prematurely or with low birth weight may be at higher risk. Neurological factors. Research does suggest that differences in brain structure and function may contribute to motor challenges in individuals with DCD, affecting the neural pathways involved in motor coordination and planning. And then finally, co-occurring conditions. There is a high rate of comorbidity between DCD and ADHD. Actually, it's 41% of these two co-occurring together. The challenges that are associated with ADHD, attention, impulse control, and executive functioning can further impact motor coordination. It's important to note that while these factors may contribute to the development of DCD, each individual's experience with the condition is very unique. And the presence of these factors doesn't guarantee the development of DCD, nor do their absence exclude the possibility of DCD. Motor challenges in DCD. So patients with DCD can have both gross and fine motor challenges. They can experience difficulties in motor coordination and the acquisition of motor skills. Some of these challenges are difficulties with balance and coordination, awkward and unsteady gait, trouble with jumping, hopping, or skipping, challenges catching and throwing a ball, and difficulty riding a bike. And then, of course, there are the fine motor challenges. Functional challenges with DCD. The motor challenges in DCD can significantly impact an individual's ability to perform ADLs and participate in various contexts. Self-care skills. They may have difficulty with dressing, including fastening buttons, zippers, and tying shoelaces. They may have challenges with self-feeding and using utensils effectively. Also may have trouble with grooming tasks, such as brushing their teeth or combing their hair. Academic performance. They may exhibit poor handwriting and slow writing speeds, affecting their note-taking and completing assignments. They may have challenges with fine motor control, things like drawing, coloring, and cutting. And they may have difficulty organizing and coordinating movements, such as using a mouse or a keyboard. And then social participation. There may be limited participation in sports or playground activities due to motor coordination difficulties. Challenges with participating in group or team activities that require coordinated movements, and there's a potential impact on self-esteem and confidence in social situations. So here are some characteristics of a child with DCD. They may appear inattentive due to difficulty stabilizing their body and joints. They may look restless, and they're frequently viewed as a behavior problem in school. The contribution of motor difficulties to academic and social problems are often overlooked. There really is no typical child with developmental coordination disorder. There's a wide range and variety of motor impairments. Some children have poor fine motor control, some have poor gross motor control, and some have both. They do tend to adopt more passive interests, and that allows them to effectively avoid activities that expose their weaknesses. So some specific gross motor characteristics are decreased coordination and balance, decreased muscle strength, immature movement patterns, awkward running and jumping, poor performance in sports, and decreased cardiorespiratory fitness. There are coexisting conditions that commonly occur with developmental coordination disorder. Some of them are ADHD, ADD, autism, sensory differences, learning disabilities, depression, and anxiety. And so here are some conditions that it's important to rule out or make a differential diagnosis. Cerebral palsy, congenital syndromes, genetic disorders, musculoskeletal disorders, neurodegenerative disorders, traumatic brain injuries, and visual impairments. So let's pause and we will do a knowledge check. Hopefully you were able to answer these questions easily. Now let's talk about the difference between developmental coordination disorder, apraxia, autism, and developmental delay. These diagnoses are commonly confused. So developmental coordination disorder is an impairment in learning or performing a motor task that are non-habitual. There's a failure to acquire age-appropriate motor skills, there's poor balance, and there's awkward movements. Apraxia affects voluntary motor control, including speech and coordination of movements, difficulty planning and executing purposeful movements, impaired ability to perform skilled or learned movements, such as speech sounds or gestures, and they may have inconsistent errors in speech production. It typically does not affect balance or coordination in physical activities, and it can affect both fine motor skills and speech production. And autism is a neurodevelopmental disorder characterized by challenges in social interaction, communication, and repetitive or restricted behaviors. There's difficulty in social interaction and communication, including nonverbal cues and social reciprocity. They may have difficulty with transition and changes in routines, and there can be a wide range of intellectual abilities, from intellectual disability to average or above average intelligence. Autism encompasses a broader range of symptoms and affects various domains beyond just motor coordination. And finally, developmental delay. This is really a broad term used to describe a delay or a lag in one or more areas of development. It can affect various areas of development, including motor skills, language, cognitive abilities, and social emotional skills. There may be delayed milestones such as walking, talking, or potty training. It can really vary widely in severity and the specific areas affected. So let's talk about the role of the interprofessional team. Service coordination and communication are crucial. This allows providers, children, and parents and caregivers to discuss options for care and address function, participation, and prevention of secondary consequences while addressing family values. Pediatric physical therapists help contribute their expertise in child development, motor control, motor learning, movement observation, functional training, and clinical reasoning. PTs can collaborate with OTs in areas outside the typical scope of PT practice or in the areas in which an individual PT may be less familiar, such as handwriting or sensory differences. These are just some examples of team members that may be involved in the child with developmental coordination disorder. So there are various settings in which we treat children with developmental coordination disorder. Due to the unique nature of their interactions with children in these environments, they may be the first clinician to consider and pursue consultation with other professionals about the possible diagnosis of DCD. So you may see these children in schools, in outpatient clinics, home health, and community and recreational settings. Now we're going to move to talking about assessment and evaluation. These play a crucial role in the developing appropriate intervention plans for DCD. Through a comprehensive evaluation process, PTs can gather information about an individual's motor skills, coordination abilities, functional limitations, and participation in daily activities. By conducting a thorough assessment and evaluation, we can understand the individual's specific motor challenges and tailor our intervention plans to meet their unique needs. So we would do a systems review where we're gathering information from both caregivers and teachers, inquiring about their performance at home, school, and the community. Standardized assessments. Some examples are the Movement Assessment Battery for Children and the Brunick-Oseretsky Test of Motor Proficiency, also known as the BOT. Observations, we would observe motor performance during tasks and activities. Functional assessments would include looking at ADLs and school-related tasks. And then finally, a collaborative approach. We're collecting information from multiple sources, which helps to ensure a comprehensive and accurate evaluation. So here are some common participation measures. Participation difficulties are often the reason why these children with DCD come to PT in the first place. And participation changes are the ultimate measure of success for the child and the family. Children with DCD participate less than typical children in school and community settings. Therefore, it's really important to establish goals that address these differences. Inquiring about participation restrictions and goals may guide the plan of care and help to determine the child and family satisfaction and success with the plan of care. The APTA Guide for PT Practice suggests it's important to use outcome measures across all domains of the ICF, including outcomes that reflects the individual's goals. It's important for children to evaluate their capacity to perform tasks related to participation. So the first one is the Canadian Occupational Performance Measure. This is an outcome measure used in PT to assess a client's self-perceived performance and satisfaction with daily activities. It really is a client-centered approach where the client identifies their own goals and priorities for improvement in daily function. The COPM provides a standardized way to measure changes in the child's performance and satisfaction over time and helps guide intervention planning and goal setting in physical therapy. The Goal Attainment Scale is a method used in PT to set individualized goals and measure progress towards these goals. It involves collaboratively setting specific and measurable goals with the patient and assigning a numerical scale to define different levels of goal attainment. The GAS allows for a more individualized and patient-centered approach to goal setting and provides a standardized way to measure progress in PT interventions. Then we have the PEGS, or the Perceived Efficacy and Goal Setting Program. This is a program designed to enhance self-efficacy and goal setting in children receiving PT. It involves collaborative goal setting between the child, their family, and the therapist, and it helps to promote active involvement and engagement in therapy. PEGS helps children develop a sense of confidence and belief in their ability to achieve their goals. It aims to increase children's perceived control and ownership over their therapy outcomes, which ultimately leads to improved engagement and outcomes. And then finally, we have the Children's Assessment of Participation and Enjoyment, or the CAPE. This is another assessment tool used in PT to evaluate children's participation in meaningful activities and their level of enjoyment. It assesses a wide range of activities across various domains, including recreational, social, and self-care. The CAPE provides insight into the child's level of involvement, preferences, and the barriers to participation, which helps the therapist tailor interventions to address these limitations. So now I'm going to have you pause, and I would like you each to click on the links to go into these individual participation outcome measures and do some investigating yourself. Hopefully you all now have a better understanding of how these outcome measures are used and when they're appropriate to choose for individual patients. Next, let's talk about observational movement analysis. OMA in a clinical or natural environment is used to identify movement quality characteristics that contribute to impaired coordination, skipping, jumping jacks, jumping rope, or bouncing and catching a tennis ball. PTs carefully observe a child's movement in real time, noting their posture, alignment, muscle tone, joint range of motion, balance, coordination, and overall movement plans. Observational movement analysis should ultimately lead to further tests and measures to examine children with suspected DCD. It allows us to differentiate between DCD and other conditions. It helps to facilitate referrals to specialists, and it can guide the PT to more specific tests and measures. Some characteristics of observational movement analysis on a child with DCD is increased time to complete tasks. You may see asymmetries or decreased coordination. You may observe difficulties with motor planning, evidenced by sequence and timing deficits. There may be increased step widths and more variability in double limb stance and stride time during gait, suggestive of a less mature pattern. All of these are examples of what you would look for while you're doing your observational movement analysis. Sometimes we don't have standardized tests to use in our clinics, and so we need to just do a motor skills checklist. So here are some examples of skills that you would look for when a patient comes to you with suspected developmental coordination disorder. You would want to look at them galloping. So children should be able to rhythmically gallop by the age of 4, standing on either foot for 8 to 10 seconds, hopping 8 to 10 times on one foot, skipping with alternating feet, standing on either foot for more than 10 seconds, which is attained by age 6, and riding a bike without training wheels. So these are some examples of things you could motor skills you could look for in a child when you don't necessarily have a standardized test. So here are some patient-reported outcome measures. PTs can document activity limitations that affect participation in the home, school, and/or community using a standardized questionnaire. Standardized questionnaires are usually completed by the patient or child, the parent or caregiver, or other significant adults. So the Developmental Coordination Disorder Questionnaire, or DCDQ, is a screening tool that was developed to assess the presence and severity of DCD in children aged 5 to 15. It consists of about 15 items that assesses a child's motor coordination and performance across different settings, such as home, school, sports, and activities. It's completed by parents or caregivers who provide information about the child's motor skills and difficulties. The items on the questionnaire cover various aspects of motor coordination, including tasks such as running, catching a ball, handwriting, tying shoelaces, or using cutlery. The questionnaire captures both gross and fine motor skills, as well as functional activities relevant to the child's age. The questionnaire does not provide a clinical diagnosis, but does serve only as a screening tool to help identify children who may require further assessment for DCD. Then the second checklist is the Movement Assessment Battery for Children checklist. This is not to be confused with the standardized test, the Movement Assessment Battery for Children. So the MABC has both a checklist and a standardized assessment. So the checklist, again, helps to identify motor difficulties and provides an overview of the child's strengths and weaknesses in different motor skills, such as manual dexterity, aiming and catching, and balance. This checklist provides an overview of the child's motor difficulties, indicating which motor skill areas are challenging for the child. It helps the PTs to identify specific areas of concern and guides intervention planning based on the child's motor strengths and weaknesses. The MABC checklist is a useful tool for summarizing a child's motor performance and identifying specific motor skill areas that require attention. However, again, it's important to remember that the checklist is just one component of a comprehensive assessment. So here are some common gross motor delays that you may see in a child with developmental coordination disorder. These delays can impact their ability to perform age-appropriate movements and participate in physical activities. Balance and coordination. They may have difficulties maintaining balance while standing or walking. They may have challenges with coordination during activities that require a change in body position. Running and jumping. They may have uncoordinated running patterns, such as poor arm swing, excessive trunk movement, or difficulty maintaining a steady pace. Ball skills. They may have difficulty catching, throwing, and kicking a ball accurately. Lack of coordination in tracking and anticipating a ball's movement, which results in poor timing and coordination during ball-related activities. Bicycling and skating. They may have trouble riding a bike, including challenges with maintaining balance, pedaling smoothly, and coordinating steering. They may also have difficulties with roller skating or ice skating, characterized by unsteady movements and difficulty maintaining balance. And lastly, team sports. Children with DCD really struggle with participating in team sports that involve complex motor coordination. Challenges with coordinating movements with teammates, maintaining positional awareness, and executing game strategies are all common gross motor delays in children with DCD. Challenges with jumping and landing tasks leading to decreased efficiency and coordination. These gross motor developmental delays can significantly impact a child's physical activity, participation, peer interaction, and overall confidence. It's really important to identify these delays through assessment and evaluation and to develop targeted interventions and support strategies. Interventions. These are first choice interventions. Developmental Coordination Disorder Clinical Practice Guideline recommends task-oriented interventions that address activity and participation restrictions along with body structure and function interventions. These are considered first-choice interventions for patients with DCD. Task-oriented interventions for children with developmental coordination disorder aim to improve motor skills, functional abilities through structured and purposeful activities. Two examples of task-oriented interventions commonly used for children with DCD are motor skills training and neuromotor task training. Some principles of task-oriented training methods include part practice to whole practice, multiple repetitions, task-specific practice in variable environments, adapting the training based on progress, increasing the environmental and task demand, facilitate self-discovery using creative methods such as encouraging the child to view the task practice in videos with the physical therapist guiding them to identify modifiable task components, and then of course providing feedback. Let's talk a little bit more about task-oriented interventions. These are based on theories of motor control and motor learning, and they focus on goal attainment through active participation and progressively increasing task demands. Task-oriented interventions for children with DCD aim to improve motor skills and functional abilities through structured and purposeful activities. So the clinical practice guideline lists 4 examples of task-oriented interventions that are appropriate for children with DCD. Motor skills training, neuromotor task training, cognitive orientation to daily occupational performance, and motor imagery. So motor skills training focuses on enhancing specific motor skills that are impaired with children with DCD. Practicing and refining fundamental movement patterns and functional activities are an example of a way to work on motor skills training. They're designed to target the specific motor difficulties experienced by the child. Neuromotor task training aims to improve motor planning, coordination, and sequencing of movements through task-specific exercise. It focuses on practicing activities that are meaningful and relevant to the child's daily life. It can involve breaking down complex tasks into smaller components and providing explicit instructions, feedback, and repetition. For example, if a child is having difficulty tying their shoelaces, neuromotor task training may involve breaking down the task into steps, practicing each step individually, and then gradually integrating them into the complete task of tying the shoelaces. So that would be part to whole practice. Neuromotor task training may involve a combination of structured exercises, play-based activities, and environmental modifications to support skill development and overall generalization. Cognitive orientation to daily occupational performance, or co-op. This is a task-oriented intervention approach that focuses on improving cognitive skills and problem-solving abilities to enhance a child's performance in daily activities. Co-op is really a patient-centered approach that focuses on improving motor performance and problem-solving skills through cognitive strategies and guided discovery. It emphasizes the child's active involvement, self-regulation, and transfer of learning to functional daily activities. Co-op involves collaborative goal setting between the child, their family, and the therapist. The child selects a specific motor skill goal they want to achieve and participates in problem solving to develop strategies to reach that goal. By setting these individualized goals, teaching cognitive strategies, and promoting self-regulation and transfer of learning, co-op aims to enhance functional performance and participation in daily activities. The involvement of both the child and their family is integral to the success of this type of intervention. And the last task-oriented intervention is called motor imagery. This is a cognitive process in which the individual mentally rehearses or imagines performing a specific movement or skill without physically doing it. It can be used as a task-oriented intervention for children with DCD to enhance their motor planning, coordination, and performance. Motor imagery is really a cognitive intervention approach, and it utilizes mental practice, visualization to improve motor planning, coordination, and performance. By engaging in vivid mental rehearsals of motor tasks, children can enhance their motor skills and transfer those skills to real-life activities. So the clinical practice guideline also recommends that along with those first choice interventions that we just discussed, they be paired with body structure and function interventions. And the clinical practice guideline recommends these 3 specific body structure and function interventions for children with DCD. So some examples of core stability training might be plank exercises, bridges, stability ball exercises. Then we have cardiorespiratory training. That would include aerobic activities, interval training, or circuit training. And then lastly, functional movement power training program. That's things like medicine ball exercises, jumping exercises, plyometric exercises, agility ladder drills. So these are some body structure and function interventions that should be paired with those first choice task-oriented interventions. Promoting gross motor development in individuals with DCD involves implementing targeted intervention strategies that address their specific motor challenges. The goal really is to enhance their motor skills, coordination, and overall functional abilities. Task modification includes breaking down complex motor tasks into manageable components. You want to provide visual cues or prompts to facilitate motor planning and execution while you're modifying the task. Motor learning principles are important. We want to incorporate principles of motor learning such as repetition, variability, and feedback. This encourages practice of motor skills in different contexts to enhance generalization. You should provide specific feedback to reinforce correct movement patterns. And then strength and coordination. You want to implement exercises that target specific muscles and coordination skills. Include activities that challenge balance, core stability, and overall body control. You want to utilize equipment such as therapy balls, balance boards, and resistance bands. And then environmental modifications. You want to create an inclusive environment that encourages active participation. You should ensure the availability of appropriate equipment to facilitate gross motor activities, and you should adapt the environment to accommodate the individual's needs. For example, reducing the distractions that are around. And then lastly, a collaborative approach. Communicating and coordinating efforts to ensure consistent support across different settings. This involves the individual in the goal-setting process to promote ownership and motivation. Next, we will look at a video of a boy with developmental coordination disorder participate in intervention. This happens to be occupational therapy, but you'll watch as he progresses through his gross motor skills with appropriate intervention. Here's the video.
It's clear that Will has difficulty tracking midline. His eyes aren't focused on it, and it's hard for him. He's working hard to even focus and look at it, at the moving object. Walking across the step stool is challenging for Will, as he has decreased balance and postural stability. Balance is part of the vestibular system, and knowing where our body is. Will's compensating by using his whole body to kind of brace itself. Difficulty catching a large playground ball, knowing where it is in relation to his body, timing and sequencing, visual tracking in order to catch the ball are all difficult for Will. Even coordination to throw the ball back is challenging. After 6 months of treatment, you can see some progress with the visual tracking. It's better, but not great. His eyes are following the moving object. Now Will has a much better sense of where he is in space. He's grounded. He's able to stand still, track the ball, catch it with 2 hands, throw it back with some coordination. His balance has improved significantly. but still under age-appropriate levels. He's not wavering as much, but he is still kind of compensating with bracing his leg against his body. His vision improved significantly by the end, which is an indication of improvement with his vestibular system and ocular motor system. He can track horizontally, across midline, diagonally, up and down, converge, diverge. Here, Will's standing on an uneven surface and catching the ball. His eyes are focused, bringing his hands midline together. He has the timing and sequencing. Higher level coordination skills such as hopscotch are easy for Will now that he can balance and jump. And walking across the step stools is an easy thing for Will. Balance improved significantly. He no longer has to compensate. He can just stand there and be still. There's no wavering, and he can focus and balance on one foot.
So I hope that video gave you a closer look and understanding of what a child with developmental coordination disorder would look like. Look at specific interventions now. So you can please open up the Word document that I provided, and you can go over the first choice interventions with each other. I give specific examples of different activities under each intervention. So please take time to turn and discuss. I hope you were able to get a better idea of what the first choice interventions would look like in practice after having gone over the document together. So next we'll talk about small group or individual sessions. So PTs should deliver interventions using a one-to-one or a small group sessions for children that are diagnosed with developmental coordination disorder. There's improved outcomes have been demonstrated in children receiving both individual and small group interventions. Caution should really be taken when using group-based interventions for children, such as monitoring for signs of anxiety, avoidance of group participation, or lack of enjoyment. So here are some supplemental activities for children with DCD. PTs should recommend supplemental activities which help to augment the first choice interventions and also that are of interest to the child. Participation in physical activities within the community that are enjoyable for the child may improve self-confidence and quality of life. Supplemental activities are activities that occur in the home or community, activities that may support the goals of the child and the parent and caregiver, and activities that are typically not included in ongoing physical therapy intervention. Some examples of supplemental activity that the clinical practice guideline recommends are soccer and taekwondo, and other physical activities, including participation in sports. Caregiver education. Providing education about teaching methods, exercises, or motor learning techniques to use at home, school, or in the community is really important for the caregivers of children with DCD. Examples of teaching strategies include breaking the task down into smaller, simple components, beginning with decreased environmental and task demands, repetition of task components followed by the whole task practice, gradually increasing the demands until the child can generalize the skill to perform the task. If the child is capable, you can encourage self-discovery of problem areas and motor imagery. Education can help to empower caregivers and provide them with strategies to address motor concerns at home and at school. So this slide is really just for your reference. These are different outcome measures that you can use to assess children with developmental coordination disorder. It goes through the outcome measure and the description and then the appropriate age in which to use each outcome measure. You can review this on your own time. So let's talk about dosage of direct physical therapy. There's evidence that supports frequent practice scheduled over several weeks or until the goal-related outcomes are achieved. The intervention dosage should be based on opportunities for practice in home and school environments and with supplemental activity options in the community. A high-frequency practice schedule of 2 to 5 times per week should be distributed between PT sessions and other practice opportunities or supplemental activities. For example, 1 to 2 direct physical therapy sessions a week with a home program and or additional time to practice during the school day. Supplemental activities should be recommended to complement the primary physical therapy intervention. Combining direct PT services with home practice and community and recreation activity helps to promote appropriate social participation for children and families. It helps to progress the child toward their goals that ultimately determine the duration of the intervention. Discharge from PT. So prior to discharge, PTs should always initiate a consultation with the child's primary physician, their parents and caregivers about their progress during the episode of care and the discharge plans. You want to discuss ongoing activity recommendations with the families. Discuss with the family how to address ongoing motor concerns and when to access further reevaluations. And then you're going to discharge when activity and participation goals are met. You want to educate the parents and caregivers about the potential need for periodic episodes of PT care based on the child and or the parent caregiver goals. Reasons to reinitiate physical therapy would be functional decline or new functional goals that are important for the child's participation. So here's a case study. I would like you to read through this case study and try to answer these questions with each other. Look over the first choice interventions, look over the assessment tools to see what is appropriate, and I'm going to give you some time to discuss this case study with each other. Emily is a 7-year-old girl who has recently been diagnosed with developmental coordination disorder. She struggles with fine motor skills such as handwriting and tying and shoelaces, and she also exhibits poor balance and coordination. Her parents are concerned about her performance at school and her ability to participate in physical activities. So go ahead and take some time now to talk with each other about the different strategies and interventions that you would use for Emily. Thank you so much for participating in my lecture today about developmental coordination disorder. I hope that you learned a lot and enjoyed this new information.